No, no, I'm
He's
sorry.
on mute.
Okay.
Nervous. I was like, is that
And Uruj, don't forget to share your slides.
I will.
Okay. Good afternoon, everybody. I am Amy Rosenstein. I'm the Administrative Director of MCPAP for Moms. Welcome to today's webinar, which is going to be focused on postpartum psychosis. I wanted to take care of just a couple of housekeeping points, and then we will get started. The session is being recorded and will be available on the MCPAP for Moms website at www.mcpapformoms.org. And a copy of the PowerPoint slides will also be on the website on the Tools and Resources page under PowerPoint presentations. Our presenter is going to stop for questions at different points during the presentation, and there will also be time for questions at the end. If you have a question, please type it into the question box during the presentation, and we will read it out for you, or else you can also click the raised hand button and we will unmute your line at the end of the session, or during the presentation if a question comes up. I just wanted to also mention that you will receive a very brief survey after the presentation. We really appreciate it if you take the time to complete it. We really find feedback to be very helpful in terms of planning for future presentations. So with that, I'd like to introduce today's distinguished presenter, Dr. Uruj Kamal Haider, MD. She is the Medical Director of Consultative Services for MCPAP for Moms and the Assistant Professor of Psychiatry and Obstetrics Gynecology at UMass Memorial, UMass Chan Medical School. Dr. Haider is also Medical Director of the Women's Mental Health Clinical Services at UMass Memorial and is a consulting perinatal psychiatrist for the UMass Lifeline for Moms network of national perinatal psychiatry access programs. Dr. Haider enjoys teaching in her clinical work and is particularly interested in postpartum psychosis, OCD, and perinatal sleep concerns. So with that, I would like to hand it over to Dr. Haider.
Great, thank you, Amy. Hello, everybody. Nice to see everyone today. So we will be discussing postpartum psychosis, and I'm going to jump right in. No disclosure. So for the objectives for today, we will go over some risk factors, some clinical features, differential diagnoses of postpartum psychosis, the overall evaluation of postpartum psychosis and what that entails, and MCPAP for Moms' role in supporting providers in this challenging diagnosis. So perinatal mental health affects us all. And you see here on the light blue box on the left, perinatal mood and anxiety disorders, often abbreviated PMADs, can mean different things. So there are many different ways that perinatal mental health conditions can manifest. So we often use the term PMAD, and that refers to depression, anxiety, and bipolar affective disorder during the perinatal time period. Now, you'll often hear about PPD, or sometimes your patients will refer to it as postpartum. I had postpartum, she had postpartum. Now, that's actually a misnomer because it can and often does start in pregnancy. So I actually like to think of it as perinatal depression or perinatal bipolar disorder. Now, perinatal depression refers to depression that occurs in pregnancy or within a year after having the baby, after the delivery, because the reality of it is depression can really occur, or mood conditions can occur at any point during that time period. And so when we think about perinatal depression, that is very different, which includes postpartum depression, that is very different from postpartum psychosis, because perinatal depression, or PPD, does not include psychotic symptoms. And so that's one of the key main differences. And PMADs, perinatal mood and anxiety disorders, occur in 1 in 5 individuals. And postpartum depression, or perinatal depression, occurs in 1 in 7 perinatal individuals. Now, postpartum psychosis occurs in 1 to 2 in 1,000 individuals, so it's far less common and more rare than the other mood and anxiety disorders that we see during this time period. Now, healthcare systems need to change to help promote perinatal mental health. And I'll just add, perinatal depression is actually twice as common as gestational diabetes mellitus. It's 10 to 15 individuals for depression, 10 to 15 individuals in every 100 for depression, and 3 to 7 in 100 in diabetes mellitus. Now, OBs always screen for diabetes mellitus because it's common, but the reality is depression is twice as common. So, you never see OBs being like, here's your insulin, see ya. That doesn't happen. So we really need to approach medical conditions and psychiatric conditions in similar ways. So perinatal mood and anxiety disorders are recognized as a major public health problem. Now, one of the biggest barriers to addressing PMADs is that they're often under-recognized and underdiagnosed. Routine screening can help address this barrier, but screening alone is not helpful. And so systems really need to be in place to help with further assessment and evaluation. And you'll hear me talk about screening throughout this presentation because it's something that's just so important, and the evidence really supports this, and we at MCPAP for Moms really support screening when adequate structures and processes are in place. And institutions like the American College of Obstetrics and Gynecology, the CDC, American Academy of Pediatrics, the Council of Patient Safety and Women's Healthcare are also talking about screening and how to do that. So the perinatal period is ideal for the detection and treatment of mood and anxiety disorders. Now, last year, ACOG, the American College of Obstetrics and Gynecology, which facilitates the Alliance for Innovation in Maternity Care, AIM, re-released the perinatal mental health bundle. And last June, they released their first ever clinical practice guidelines, often abbreviated CPGs, for maternal mental health. And it includes recommendations on screening, diagnosis, and management of mental health conditions, including bipolar disorder, acute suicidality, postpartum psychosis. And in the CPGs, they mentioned doing an MDQ, which is a mood disorder questionnaire, to screen for bipolar disorder because of that rare but potential risk of postpartum psychosis, which is so critical. And they also mentioned that screening for bipolar disorder is important because giving SSRIs, antidepressants, Zoloft, Prozac, Effexor can inadvertently put someone into mania. So this is a really big deal that ACOG is really talking about this in their CPGs, and this is the first time ever released last year. So again, the patient safety bundles are a structured way of basically improving the processes of care and patient outcomes based on evidence-based best practice guidelines. And this is done to address clinically relevant medical obstetric conditions in pregnancy and postpartum. And the goal of patient safety bundles, PSBs, is really to improve the way the care is provided to improve mental health outcomes long term. So just to reiterate and reemphasize this, the screen for perinatal mental health conditions consistently says to do it throughout the perinatal time period, including but not limited to obtaining individual and family mental health history and at intake, and as often as possible, screening for depression and anxiety at the initial prenatal visit, later in pregnancy, and in the postpartum period, though that postpartum period is not exactly defined, but it's something the AAP, American Academy of Pediatrics, also supports doing screening during pediatric well child visits. And again, to emphasize, screening for bipolar disorder before initiating pharmacotherapy for anxiety and depression because of that inadvertent risk of mania and potentially postpartum psychosis. Now, perinatal mental health and substance use disorders are common, undertreated, and the leading cause of maternal death in the US. So we know that 1 in 5 perinatal individuals around the world will suffer from a maternal mental health complication. Now, I'd like to draw your attention to the pie graph on the right. And so the blue is the proportion of treated women who screen positive for depression, and the red is the proportion of untreated women. Now, what this study shows is that if someone screens positive for depression, less than 25% of women, perinatal individuals, actually get to an initial mental health appointment. That's pretty low. Now, screening in general, it's often it can be secondary to numerous factors, and that can be secondary to barriers in treatment, adverse social determinants of health, racism, clinician shortages, patients don't feel comfortable disclosing their symptoms, general distrust of the medical system. So optimizing perinatal mental health can really break that transgenerational impact of maternal depression. And the perinatal period is really ideal for the detection and treatment of perinatal mood and anxiety disorders, and frontline providers like you all have such a pivotal role here. Now, I'd like to also draw your attention to the statistic on the bottom, the blue bold, which is so important. Mental health conditions are the underlying cause of 23% of maternal deaths in the United States. Now, that comes from the 2017 to 2019 Maternal Review Mortality Committee, which showed that mental health conditions are almost 10% higher than any medical cause. The highest was actually postpartum hemorrhage at 13%. So 23% of maternal deaths in the United States are due to mental health conditions, and perinatal mental health and substance use conditions are clearly a big cause of maternal mortality, driven by both suicide and unintentional overdose. I think substance use is really something that we can't forget here. So in prior data, I'll say when they looked at that mental health data, 100% of them were shown to be preventable. Now, this is really important data, and the data for people of color, I'll say, is that among individuals who have been marginalized or oppressed, the rates are overall higher and the treatment rates tend to be lower. And so the studies show that the rates are generally higher than 1 in 5 in those specific populations. Now, this can come off as alarming at first, but in my opinion, I really feel like it presents an opportunity for us all as a treatment community to talk about education and improvement, especially when we're talking about rare conditions like postpartum psychosis. Now, so bipolar disorder is particularly common during the perinatal time period as compared to other conditions. Now, this study is often cited. It was done by Catherine Weisner in 2013, published in JAMA Psychiatry. And so this was actually, so this pie graph shows the blue is the unipolar depressive disorder at 69%, bipolar disorder at 23%, other disorders at 7%. And I'm going to go into these numbers. So this was the largest scale depression screening of postpartum women, and really the first time up until date that a full psychiatric assessment had ever been done in a study of postpartum women who screened positive for depression. And the study included a depression screening of 10,000 women at a very large birthing center who had recently delivered, and it revealed a very large percentage of women who suffered from recurrent episodes of major depression. Now, so the blue highlights that. The most common primary diagnosis was actually unipolar depressive disorders at 69% of those who had screened positive for depression, and almost 2/3 had comorbid anxiety disorders. Now, of the women who screened positive for major depression, 23% actually had bipolar disorder, the majority of whom who had never been diagnosed by a psychiatrist or a psychiatric clinician ever before. And so I feel like it's important for clinicians to really know that the most common clinical presentation in the post-birth period is much more complicated than a single episode of depression. And the depression is recurrent. 2/3 of the time, it's superimposed on anxiety. And we also have to think about bipolar affective disorder. Now, there's often a delay in correctly diagnosing bipolar disorder, and we really have to think about identifying not only that depressed phase, but also the manic and hypomanic phases as well, because it's truly an episodic illness over time. And we have to note that the postpartum phase is the highest risk for new episodes of mania in a woman's life. Greater than 50% of the time it occurs of new episodes of mania in a woman's life are happening after birth. So this study shows that that's a very high rate of bipolar disorder that had ever been shown in a population screen for postpartum depression before. And it's significant, as I had mentioned before, because antidepressant treatment can inadvertently put someone into mania or hypomania if they in fact have bipolar disorder, and it can really worsen the course of that bipolar disorder illness as well. Now, MCPAP for Moms can help provide a solution by building the capacity of perinatal care settings to provide mental health care. Now, MCPAP for Moms was developed to help navigate the perinatal mental health arena, and we provide services to any Massachusetts clinician in a medical setting and in a medical home to improve their knowledge and skills in addressing perinatal mental health and substance use disorders through three main mechanisms that we see here: research and referral, education, and perinatal psychiatry consultation, which includes the phone calls and the one-time assessments. So for example, if an obstetric clinician identifies a patient who screens positive for a perinatal mood or anxiety disorder, they can call MCPAP for Moms and speak with a perinatal psychiatric clinician who can provide management guidance, individual indication for psychotherapy, and or arrange for a one-time consultation if indicated. Now, our MCPAP for Moms psychiatric consultants can also see patients for a one-time assessment if indicated. And after that, they provide recommendations to that patient's calling frontline provider to help them give direct mental health care to their patient going forward. Now, what we have seen is that the consultation really is the engine of MCPAP for Moms. So MCPAP for Moms was born 10 years ago, and since then, MCPAP for Moms has trained and enrolled 77% of the obstetric practices in the state of Massachusetts for a total of over 18,000 encounters for over 10,000 perinatal individuals in the state of Massachusetts. And we've really enjoyed being a part of this process with you all. Now, since the inception of MCPAP for Moms, as our psychiatric consultants make recommendations to the calling clinician to help them treat patients through phone call with a clinician or face-to-face with a patient, what we've really seen is that the consultation truly is the engine of this well-oiled machine. Now, because of consultation and the education provided, what we have seen is that our 7 psychiatric consultants indirectly assist many more patients than would be possible on a one-to-one basis, especially if that calling clinician is able to then go to manage other patients during that time. So as we'll see from recent data, this is how MCPAP for Moms has worked on a much larger calling scale. On a much larger scale, the calling clinicians can learn from us and are empowered by each encounter to then go and apply that knowledge that we learn on the phone with the psychiatric consultant, or through the face-to-face assessment and the medication recommendations that were given in the assessment and plan. And they can apply this knowledge going forward to other similar patients. So treatment trends suggest that MCPAP for Moms helps clinicians treat more complex illness over time. And improving frontline clinician, so this study was done by Grace Masters. She was our MD PhD student at UMass. And what she looked at was improving frontline clinician capacity to address depression and bipolar affective disorder among perinatal individuals. And this was the first time that a longitudinal analysis of MCPAP for Moms was done. And this is really the first research that we have on Access Program impact on frontline clinical practices longitudinally. And so what we see here on the x-axis is the time period, and the y-axis is the fraction of encounters that end in clinician providing treatment. Now, looking at the clinical encounter data from MCPAP for Moms on the bottom from July 2014 to June 2020, the telephone consultation, for example, discussing indicated treatments, effectiveness, and counseling pearls, is really most effective in changing provider behavior in that they treat more complex illness over time. So we looked at the consultations over time for bipolar affective disorder, which is that blue dotted line on top, and the black dotted line is any psychiatric diagnosis, and the red straight line is unipolar depressive disorders. And what you see here over time is that the blue dotted line for bipolar spectrum disorders actually goes up. The black dotted line for depression actually went down over time or more or less stayed the same. And so what this indicates is that while it's unexpected that our frontline clinicians calling MCPAP for moms manage conditions like bipolar disorder or even postpartum psychosis, with support from our consultants, they can and have often initiated pharmacotherapy until longer term psychiatric treatment can be secured and found for their patients. Now, so the key thing, so increased utilization of phone consults was significantly associated with the rates at which clinicians provided direct mental health care for any diagnosis. So we see here that the incidence rate ratios went up, the 1.30, 1.31, and 1.25. But most importantly, I'd like to highlight this slide, which shows that increased utilization of one-time assessments was significantly associated with the highest rates at which clinicians provided direct mental health care for any diagnosis, especially bipolar affective disorder. And so, so for bipolar spectrum disorder, the incidence rate ratio was 2.12. And so what this tells us is that when looking at one-time face-to-face assessments with a perinatal consultant and the patient directly, increased utilization was significantly associated with the rates at which the provider provided direct mental health treatment to their patients after an encounter. So this is really impressive data because it suggests that our face-to-face consultations have really increased clinicians' willingness in the state of Massachusetts to treat bipolar disorder with support. And I have to say, bipolar disorder in itself is quite it's a complicated diagnosis, even for many psychiatrists to manage and treat on their own. So patients with support see addressing perinatal bipolar disorder as an important part of their role as obstetric professionals. I'm a lot less scared to prescribe medications than I was probably 4 years ago because I see that the benefit outweighs the risk. So I won't start somebody on a bipolar medication if I think they're bipolar or have bipolar disorder. But if they've been on it and I call and I talk to a MCPAP for mom psychiatrist and we talk through the case and they think it's appropriate, then I'll happily prescribe it, said one provider exposed to MCPAP for moms. So I'd like to present a clinical case briefly. So this is a patient who had been referred to me in my women's mental health care clinic at UMass after her second psychiatric hospitalization, and she was speaking rapidly. So with this data is from when she, that her husband had described immediately when she was discharged from the hospital after a very prolonged and complicated delivery. And so I had seen her a couple of days after this point. And within hour 4 to hour 24 to 48, you see the progression of her clinical symptoms. And so the husband reported within hour 4 of being home, the patient started speaking rapidly and pacing around the house in an agitated fashion. Hours 10 to 12 of being home, so just a couple of hours later, she then locked her husband out of her house and started gripping the baby in a bizarre way. He was able to get back into the house and at this point became very confused and obviously concerned. Just 3 hours later, so less than about half a day of arriving home from discharge, she started pacing up and down the stairs with the baby, again locked the husband out of the house and refused to let the husband in. He became really concerned. He had to break down the door to walk in. Less than 1 day of being home, her behavior became floridly psychotic. So she was showering with her clothes on, thinking that this was also normal. She then went outside and was grabbing rocks and pebbles and putting them in the washer and then putting them in the dryer. And her husband asked her, "What are you doing?" And she looked at him in a very non-bewildered way and said, "Oh, I'm just doing the laundry." She then started filling the cabinets with water and proceeded to flood the kitchen, which was on the front floor of the house. So the husband immediately called 911 and she was sent to the hospital for further psychiatric care for the postpartum psychosis. So I want to talk a little bit more about bipolar disorder and postpartum psychosis. So we do know that bipolar disorder in pregnancy is associated with negative outcomes. And the majority of the time, postpartum psychosis occurs in the context of bipolar disorder. About 70% of the time is what the data shows. And I'll present a study at the end that shows that this is not always the case, but this is what we know to date. So pregnancy in itself does not protect against mood episodes. And bipolar disorder, like depression, is associated with low birth weight, preterm birth less than 37 weeks, and small for gestational age. There is also an increased rate of C-sections. So mood elevation can lead to behaviors with known perinatal risk. So for example, they can engage in substance use, high-risk driving, hypersexuality, sudden promiscuity. They may evaporate their savings account in a very short period of time for an unknown reason. So many similar behaviors can certainly occur. And bipolar disorder increases the risk of postpartum psychosis. This we know. Now, postpartum psychosis occurs in 1 to 2 in 1,000 women. So this is less than 1%. This is a very rare diagnosis, but when it does happen, it is a psychiatric emergency, a red flag, high concern. Greater than 70% of the time it occurs in bipolar disorder. Most of the time, the studies will indicate that the highest risk is immediately after 24 hours to a month after giving birth. Clinically, am I seeing this? Most of the time it can happen, but not always. For example, I have a patient who was starting to develop symptoms of postpartum psychosis a year after she gave birth because her toddler, her older toddler, went through a very difficult and prolonged sleep regression. And then the 1-year-old baby started to not sleep. And this really took a toll on her. And she started to become psychotic. So that time period can certainly be clinically variable is what we're seeing. It is hallmarked by mood symptoms, psychotic symptoms, and disorientation. We always want to rule out medical causes of delirium. It is a true psychiatric emergency. There is a 4% risk of infanticide, 5% risk of suicide with postpartum psychosis. And so therefore, not just moms, right, not just the perinatal individual's life is at risk, but everyone involved in that family unit, including the baby, including everyone at home. So we really need to take that account and take this diagnosis seriously, especially if someone has a previous diagnosis of bipolar disorder, schizophrenia, previous psychotic disorders, or previous history of postpartum psychosis or family history of postpartum psychosis. So preventing decompensation among women with bipolar disorder is critical. We want to look at prophylaxis with a mood stabilizer or other indicated medication treatment. We want to look at a birth plan. We want to engage in very close monitoring. And we want to collaborate very closely with newborn medicine. There should always be a plan for infant feeding, and we want to support adequate sleep. We want to limit stress as much as possible and support maternal-infant bonding. Sleep is so critical, and all my patients and all my trainees know that, especially in that 3rd trimester to postpartum phase, you really can't appropriately and adequately treat a perinatal individual, especially one with a diagnosis of bipolar disorder or similar diagnoses, without discussing sleep and coming up with a plan and discussing who is involved and who can engage and support the perinatal individual during that time. And it's not always as clear-cut and easy, but I do think the discussions need to be had. So what I'll also say is that so there are many risks to bipolar disorder, and even having the condition really makes this a high-risk pregnancy. So for the risks of bipolar affective disorder during pregnancy, what we do know that it's mostly based on registry data with numerous confounding factors, and oftentimes the studies are too heterogeneous to do a proper meta-analysis. So could it be that it's the psychiatric illness or the lifestyle or other things like untreated illness that could contribute to these poor pregnancy outcomes? We're not 100% sure, but we do know that you need to treat the bipolar disorder. And we also know that abrupt discontinuation of mood stabilizing medications or any other medication treatment option in pregnancy is a known risk factor for mood episode recurrence overall in these patients. So just wanted to highlight that. So the pathogenesis, what exactly is going on? Now we know for postpartum psychosis, there are many different factors, and there are different theories and papers that have discussed these factors. There are known genetic, immunologic, and hormonal factors, and we know that sleep deprivation is a big trigger. So we know that bipolar disorder in itself is highly inheritable. So children with one parent who have the diagnosis of bipolar disorder are going to have a 10 to 25% chance of developing the disorder themselves. And children with two parents with the disorder have up to a 50% chance of developing the disorder themselves. I have a patient currently that I'm treating who has bipolar 1 disorder, had previously met her husband in a support group for patients with bipolar disorder. And so he also had that diagnosis. So their current toddler has a very high chance of developing the illness, and they know that. And that discussion was part of the plan in the preconception planning plan for this family as well. So they were very much aware of that. And so it's really just a lot of psychoeducation and support, and mitigating risk factors later on and keeping everyone stable. So there is evidence that in terms of immunologic factors, there's evidence that there's dysregulation of various immunomodulatory factors in postpartum psychosis with overactivation of the monocytic and macrophagic arms of the immune system, and this is still being looked into. And there are many hormonal factors involved as well, but I just want to highlight, this is not a hormonal disorder. This is a very vulnerable time in a perinatal individual's life due to hormonal shift. So not the absolute levels of hormones, but that sudden withdrawal of estrogen and progesterone that affects the body and the mind in some individuals more than others. And it's really a reason you cannot treat postpartum psychosis with hormones. Now, let's talk a little bit about sleep and talk about the sleep cycle and how and why exactly this plays a role. So when one has an infant or a newborn, this can lead to disruption of your circadian rhythm. Now, why? So REM and stage 3, we know are responsible for restorative sleep. And when you have an infant due to caring and feeding for that infant, Q1, Q2, Q3 hours around the clock, many weeks to months straight, sometimes without a break, this can really make an impact. So we know, so looking on this graph, the normal sleep cycle, there are 3 non-rapid eye movement stages known as NREM, non-REM, and 1 rapid eye movement stage, REM. And this makes up 1 full sleep cycle, and an average cycle lasts about 90 minutes. So stage 3 is often known for restorative sleep as well. The delta is restorative sleep and mood stabilization. So when this sleep cycle is persistently disrupted and you're really not gaining restorative sleep and going through the full sleep cycle consistently, and you're waking up every 1 to 2, 3 hours, this can really make an impact and be incredibly exhausting and triggering for a lot of our patients. So this can certainly be, a big reason and cause. So I also I want to add one thing here, just going back, finalizing the importance of sleep. In my last webinar on zuranolone, and we had discussed some of the trials for zuranolone, and I'll also add that in the double-blind placebo-controlled trials for brexanolone, zuranolone's cousin, which is brexanolone is the IV version, the placebo responses of those patients were robust and significant in the inpatient setting. And so those patients, those placebo groups had a significant reduction in HAM-D scores for depression the depression scores, the HAM-D. And so what that tells us is it indicates the importance of sleep in a very sensitive time period. And those patients in those placebo group in the inpatient setting they were able to rest and they were able to have consistent, straight sleep throughout the night. And so that really speaks the importance of nurturing and sleep and rest and just overall wellness in our patients and this perinatal impact. And so I thought that was important to share that placebo, is a evidence-based way to really support that fact and the importance of having our patients sleep. What are the risk factors for postpartum psychosis? So we know that there's a history of postpartum psychosis is a certainly known risk factor, and the number one risk factor. A history of bipolar affective disorder, schizophrenia, or schizoaffective disorder, a family history of postpartum psychosis or bipolar affective disorder, a first pregnancy, discontinuation of psychiatric meds for pregnancy, perinatal or neonatal loss, and sleep deprivation. We also know that there are certain medical conditions involved. Diabetes can certainly be a risk factor. Obesity can be a risk factor as well. So many different risk factors. A personal history of postpartum psychosis certainly being the first one. Now, risk of harm to baby when mom has thoughts of harming the baby. So we're going to discuss when a patient presents to having thoughts of harming the baby, how exactly do you clinically differentiate between is this postpartum psychosis and is it not? So I like these two graphs because they really sum down what is postpartum psychosis, what is not, what can we look at. So in OCD, anxiety, depression, patients are always going to have good insight. The thoughts are going to be intrusive and scary, and they're going to be disturbed and nervous and anxious and sometimes even ashamed that they have these thoughts. There are not going to be any psychotic symptoms, and these thoughts are not going to cause anxiety, and these are going to be low risk. Versus in postpartum psychosis, the patient has poor insight, the patient will have psychotic symptoms, and there will be delusional beliefs or distorted reality present. And in fact, these are sometimes called altruistic delusions, which we'll get to in a second. And these thoughts are always high risk. That is red and bolded on the bottom right for a reason. This is a psychiatric emergency and the patient needs to be sent to the ER. So in the postpartum period, I think it's always reassuring and important to remind our patients that 70% of the time, patients will experience intrusive or unwanted thoughts due to depression, anxiety, or anxiety-related disorders, or a combination of these. Now, when assessing for risk of harm to the baby, it's important to determine if the thoughts are ego-dystonic or ego-syntonic. And ego-dystonic thoughts, which would fall on the left side of the two graphs, the patient has insight as it states the thoughts are distressing, cause the patient anxiety, versus ego-syntonic thoughts, where the patient has little to no insight, and the thoughts are actually reassuring to the patient and less likely to cause anxiety. So they completely think these scary thoughts are normal, and that's really the grave concern here. They don't have insight into what's going on, and they need immediate help and treatment for that reason. Ego-dystonic thoughts are more common, far more common than ego-syntonic thoughts, because they often occur secondary to this anxiety disorder. Or anxiety-related disorders like OCD quite commonly. And ego-dystonic thoughts of harming the baby are unlikely to be acted on because the patient often experiences guilt and shame around these thoughts. And so, for example, I have a patient, I will sometimes actually hear, Dr. Haider, my patient has been in her wet diaper all day, and I'm afraid to put her on the changing table and change her diaper because I'm afraid to accidentally molest her. And I'm just so embarrassed about this. So that is not postpartum psychosis. The patient is embarrassed by those thoughts, doesn't want to actually act on these thoughts. She has good insight, and she is embarrassed by these thoughts. With ego-syntonic thoughts, they're far less common, and the patient lacks insight and actually finds the thoughts to be reassuring. So, for example, the patient may feel the baby is better off without them, or even have altruistic delusions about harming the baby. So when ego-syntonic thoughts harm the baby, they're often in the context of postpartum psychosis or another psychotic illness. That's a true psychiatric emergency. The patient is high risk, needs inpatient level of care. Now, what are the signs and symptoms of postpartum psychosis? The rapid clinical deterioration is key. The patient can clinically deteriorate very quickly in a very short period of time, even sometimes within hours, less than a day, less than a few days max. There it is. It involves shifting mental status, psychotic thoughts, hallucinations, delusions, disorganized behavior, thought disorganization. It can also be accompanied with irritability. The patients can just be irritable mood, just have an off day, anxiety, psychomotor agitation, manic or depressed mood that can be reflected in the nature of their delusion sometimes. Usually occurs within 2 weeks. Usually it is a medical emergency and requires rapid intervention and hospitalization. Now, what are the clinical features? So I'd like to talk about this in detail for this and the next slide, because these are quite important. So the thought content, the part of the psychiatric mental status exam. So thought broadcasting, ideas of reference may occur. They can be persecutory, jealous, paranoia in nature. They have delusions of grandiosity, overall disorganized thinking, and flight of ideas. Thought process is the most important part of the mental status exam, in my opinion, especially when we're talking about psychosis. Complete disorganization. Perceptions, they can be command, auditory, visual, olfactory, tactile hallucinations. What are the actual thoughts? So the individual can have both scary thoughts and be horrified by them. Upon assessment, psychotic thoughts tend to be more bizarre. And I'd like to talk about this for a second, because psychotic thoughts can get missed because there's this misconception that the patient doesn't have to be horrified by the thoughts or really, really, really scared by them. So both psychotic and intrusive thoughts from OCD, anxiety, the patient can actually have both scary thoughts and be very terrified of them, by them, depending on when those thoughts are occurring in the timeline of the illness. So upon further assessment by a psychiatrist, the thoughts actually tend to be more bizarre, and it becomes clear that it's not an intrusive thought when it's true postpartum psychosis. So for example, I had a patient, she was very scared by her thoughts and she wanted to protect her baby. And because she was so horrified by the nature of these thoughts, she willingly handed her baby to her husband for him to take care of her, because she was truly afraid that her baby was possessed by an alien. And she was very much scared by these thoughts. So that is postpartum psychosis. That is not anxiety. That is not OCD. And in any other psychiatric diagnosis, they would actually have more insight and clarity of thought and genuinely not believe the patient was possessed by an alien. So luckily in that specific case, we were able to discern the exact nature of her thoughts early enough before they progress further, and we sent her to the hospital immediately. Impaired sensorium. This is also very important. I want to highlight this for a second, because the patient's sensorium can be waxing and waning in nature in postpartum psychosis, and this is very important. A patient can actually appear to be happy or intact, and in rare cases may actually appear to be functional if they are caught in the middle of this waxing and waning picture, but it is unfortunately misleading. And so a psychotic individual may think that others may stop their plan, or they have voices that are telling them to carry on the plan, or they're hearing voices that are telling them not to tell anyone about the plan. It can be quite scary, but this actually is this is unfortunately misleading, because a psychotic individual, they can be relatively intact in one moment, and then an hour or a couple of hours later can have worsening auditory, visual hallucinations, or even delusions. And so when the psychotic break occurs is unfortunately sometimes when we hear about it. And so I just want to emphasize, in light of that information, that early detection and discussion of previous psychiatric history and previous family psychiatric history, along with discussions like medication and sleep, is critical, and it really needs to be done as early as possible, and getting these patients connected with a mental health provider or a treatment provider as early as possible is critical as well. And so clinical features, what does the patient look like? We want to ask about activities of daily living, limited self-care. Are they engaging in self-care? Do family members think patient is acting differently? Has patient been acting differently since the baby was born? I will often ask these questions. These are so critical. And this really speaks to the power of family members in this diagnosis, because oftentimes, almost always, unless the patient is presenting with these symptoms for the first time at their 6-week, follow up with their obstetrician, these family members of these patients are really living with these patients 24/7, day and night, and they are hearing and experiencing these symptoms firsthand. And so they really pose a really big opportunity for engagement and education as well. And so talking to families is so critical due to the episodic nature of this affective illness, the bipolar disorder, and to really get accurate histories of psychosis, previous manic or hypomanic episodes. And, remember, patients, when it's true mania, patients really like that feeling of being high, and they can't always recall these episodes. And so usually, with some exceptions, patients are more likely to only recall their depressive episodes. So again, just really even more evidence that engaging the family and asking clinical questions and getting that collateral is just so important, as you would do if you were discussing a diagnosis of bipolar disorder for the first time. And so, other clinical questions I always ask, or that you can ask your patients: have you had periods of increasing energy lasting at least 4 days in the past? Were these episodes accompanied by high mood, less need for sleep, rapid speech, racing thoughts, productivity? Have others noticed in the past if you were very active, unusually happy, talking too fast, needed to slow down? What question I like to ask is, have others told you that you are really happy for no reason? Because they may not notice themselves, they may not have the insight, but have others commented like, hey, XYZ, you're like really happy, you're really excited. Do you recall other people saying that to you? Collateral from family members is again critical. How can we detect postpartum psychosis? So early recognition and secondary prevention are so critical. Now, there is no form of primary prevention for postpartum psychosis. I'm often asked that. There's no way to actually prevent it. So, for example, there's no vaccine. We can't just offer a statin or an aspirin before a cardiac event occurs. But what we can do is we can emphasize early recognition and secondary prevention. And so what this means is really empowering providers and patients and families to help with early disease detection, or even utilize EPDS or other validated screening tools to target those patients who may screen positive for depression or anxiety and other PMADs, and then further evaluate them with a clinical assessment to identify patients at higher risk for more acute mental health conditions. And so we want to screen as early as possible for current mental health problems, discuss a history of psychiatric treatment, a family history of mental illness, EPDS, mood disorder questionnaire, PHQ-9, GAD-7, all validated screening instruments in the perinatal population that we can utilize. Enhancing mental health and emotional support is key as early as possible, even in the preconception phase, if that's a possibility, or at least getting them connected with a treatment provider to discuss these things. Psychoeducation, sleep, exercise, diet. 911 crisis, the Massachusetts Behavioral Health Helpline, which I'll get into in a second, and never leave mom alone with the baby. That's critical. We want to get them immediate help. And MCPAP for Moms is also here to help. And so, I want to empower you all that there are things that we can do to be proactive. In light of everything we've discussed today, it may feel like, well, do we just sit around and wait for postpartum psychosis to occur? It doesn't always have to feel that way. But I think what we can do as, as treatment providers is to have a discussion on how to reduce emotional complications early and with family members or with significant others. That would be really helpful. And so my goal with this presentation today really is to lend you that support and let you know that MCPAP for Moms is here as an option. And so we can maximize that chance of early detection and really detect those early on and recognize those patients when things start to head downward. So reducing risk. So women with perinatal individuals with bipolar affective disorder should really remain on medication during pregnancy to avoid postpartum relapse. We want to initiate treatment immediately in patients with a history of postpartum psychosis. Sleep is so critical, as we had discussed a couple of slides earlier. And with help, the evidence says this, and I clinically see this too, patients with postpartum psychosis can achieve full remission and functional recovery. The plan, let's start utilizing family members in our plan, our partners, and talk about sleep. So many things that we can do in the plan for these patients. And so what do I do if there is a psychiatric emergency? Now, if there's a concern for suicide or postpartum psychosis, immediately the first thing to do is to take the baby away from the mom and call 911. Behavioral health, the Massachusetts Behavioral Health Helpline and crisis are always options. Now, the criteria to get someone to the hospital in the state of Massachusetts, there are 3 criteria. It's risk of harm to self, risk of harm to others, and you can't function, and the patient can't function in the community. And we don't expect you to know these things right away. And that's where MCPAP for Moms is here as an option. That's where we would want you to call us, and we can help guide you through this process to talk about where is the patient in this picture? What do I do? How do I even send them to the ER? You know, how do I fill out a Section 12? These are all absolutely appropriate things that we can discuss with you on the phone and talk through with you. So even if someone doesn't explicitly say, I want to kill myself or my baby, if they're unable to care for themselves, that can certainly warrant an inpatient hospitalization. And again, that's something we can talk about with you. Now, the Behavioral Health Helpline, it's available. It's a wonderful resource that was opened last year. The number is 833-773-2445. And if we could put that in the chat, Beth, that would be great. It's open 24/7, 365 days a year. Anyone can call, text, or chat the Massachusetts Behavioral Health Helpline, even family members, by the way. And it's staffed by trained clinicians who will stay online with you until you get the support you need. So in the middle of the night, if something comes up, that is an absolutely appropriate option. They connect patients and families to crisis support or community behavioral health centers, CBHCs. There are over 20 of them in the state of Massachusetts right now. And they can also send patients to the ER. So they can they can call mobile crisis, send them to a CBHC, send them to the ER. It doesn't always have to be the ER, but they will appropriately triage that process. You know, imminent risk versus non-imminent risk, that's always such a concern. How quickly is something going to happen? What's the, what's the level of danger involved, the timeliness involved, and that's something we can certainly also talk about with you. So please call MCPAP for Moms at any point and we can guide you. I would like to end with this study that was published in the American Journal of Obstetrics and Gynecology, February of last year. And this study looked at postpartum psychosis diagnoses during delivery hospitalizations and postpartum readmissions from a 3-year time period of 2016 to 2019. What this study did, it was a retrospective cross-section analysis, and it aimed to determine trends and risk factors for postpartum psychosis during delivery hospitalizations and postpartum readmissions. So it looked at it looked at 10 million retrospective registry-based data, and it looked at the diagnoses of postpartum psychosis during the delivery, hospitalization, and upon readmission about 60 days later to see who actually had these diagnoses and what risk factors were involved, essentially. And so one of the things was that we saw as a result of the study was most readmissions with a postpartum psychosis diagnosis occurred within 0 to 10 days of discharge. So 43% of readmissions actually immediately occurred during this time period. And so this chart is important because it shows that both delivery hospitalizations and postpartum psychosis diagnoses readmissions with the postpartum psychosis diagnosis actually increase in that time period. And so the y-axis is postpartum psychosis diagnoses per 10,000 delivery hospitalizations, and the x-axis is the period of time of those 3 years. And the blue straight line is postpartum psychosis diagnosis at delivery, and the yellow line is on the bottom is postpartum psychosis diagnoses upon readmission about 60 days later. And it showed that while still rare, the prevalence of postpartum psychosis is in fact increasing slowly over time. So both delivery hospitalizations and postpartum readmissions with that postpartum psychosis diagnoses did in fact increase over that time period. And so this is going to the demographics, and I would like to just hone in on this slide. So the result of this slides show that the risk factors associated with the highest odds for postpartum psychosis diagnoses at delivery were in fact schizophrenia and anxiety. And so in addition to bipolar disorder, but the highest were actually schizophrenia and anxiety diagnoses. And so the clinical factors with the highest adjusted odds for postpartum psychosis readmissions included postpartum psychosis at delivery of 5.8, depression at 3.7, bipolar 2.9, schizophrenia spectrum disorder 2.0. So I'd like to highlight the blue oval on the left. So delivery hospitalization, the N-adjusted odds ratio. And so this is the most important result. So in models analyzing postpartum psychosis diagnosis at delivery, the risk factors associated with the highest odds actually included schizophrenia, which was the highest at 8. That's the 7.99 that we see. And then we see anxiety disorder at 5.20. And then we see bipolar disorder at 5.6. So schizophrenia and anxiety first, and then bipolar disorder. Stillbirth 3.9 certainly makes sense. Trauma. Very distressful for mom and that family unit. Depression disorder at 3.1, and then substance use disorders at 3.0. So what this study tells us is that there are in fact other factors involved in postpartum psychosis beyond just bipolar affective disorder as we've historically thought. And so just to close out my clinical case, I just want to highlight the rapid clinical deterioration of this patient and how quickly this occurred. And she was able to become stable and in full remission on her lithium and Seroquel. And so I am going to stop sharing. And all right, did I stop sharing, Beth? Am I off?
Yes, you're all set.
Okay, great. And if anyone has any questions, feel free to ask them now. I know we have just a few minutes.
Uruj, this is John. I just wonder if you could talk a little bit about the importance of if you're a single parent, of having a support person and to monitor this behavior. As you say, it can change really quickly, and if someone's left alone.
Yeah. That's a great question, John. And, you know, single parent families, it's always just so challenging. What can we do? And I would say first and foremost, education, psychoeducation, letting that single parent know as early on, even during the prenatal visits, what does support look like? How can I offer that support? What resources can we offer early on? And then discussing the diagnosis and clinical features that they may be aware of. And is there a friend or a family that you can utilize during this time period? And there may not always be, and I wish there was a clear-cut answer on how we could support our single parent families. But is there someone else, especially during such a critical time period, especially in that third trimester to postpartum phase, where we could, you know, give that family or friend, you know, psychoeducation and what do early clinical features of postpartum psychosis look like, which may not always be florid psychosis. It could be mood changes, it could be sleep disruption, it could be irritability, it could be severe anxiety. So, you know, letting them know about that and coming up with this, discussing and coming up with a sleep plan. And also talking about, I think this is a good opportunity to talk about, do you want to breastfeed your baby? And it doesn't make you any less of a lactating parent or a perinatal individual if you choose not to. But, you know, giving the baby a bottle is a way for mom or the perinatal individual or one who identifies as a lactating parent to also stretch out those hours of sleep. Because if there is someone that could help, you know, a friend or a family member, even for a short period of time, they can give that baby a bottle while that parent sleeps at night. So I do think the third trimester to postpartum, sleep plan should also be discussed in context of how to feed that baby and what that looks like. And bottle feeding can certainly, prolong the amount of hours that mom is asleep and the parent is asleep, and hitting restorative sleep as well. I also just want to highlight the Massachusetts Behavioral Health Helpline is a great option to give even on labor and delivery units for a lot of our patients, because if something were to change rapidly, like in the middle of the night when that patient is discharged, they can have that information to call a licensed clinical professional in the middle of the night when MCPAP for moms or the obstetrician is not available, and they can triage appropriately depending on crisis or whatnot, and talk about ways to support the children at home if no one else is available. So just wanted to put in a plug for that. But that's a great question and always a challenge.
And Uruj, I think we've known of a couple situations where the parent wasn't an official single parent, but the partner was having their own mental health difficulties and postpartum issues and was not supporting mom.
Yes.
So that is also a real risk factor if the partner is not in the household.
Yeah, I completely agree. I also want to say, speaking of partners, those validated screening instruments are validated in EPDS, PHQ-9, GAT-7. They are also validated in fathers as well. And so early connection to mental health providers and treatment providers for mom and dad, any of the spouses involved, the whole family unit, is so important. And you can give those scales to any of the parents early on, to detect who is at higher risk, or if they're feeling depressed or anxious, even when their wife or husband, got pregnant early on and they don't know what to do. And so early connection with treatment providers is critical.
Thanks.
Great question, though. So I believe we're at 101. Thank you, everyone, for joining. Hope this was helpful. I can stay on for a few minutes if needed, if anyone has any last-minute questions.
And just a reminder that people will be getting us a brief survey. We hope you'll fill that out, and also that the webinar posting and PowerPoints will be on our website, so you can look there in a few days if you want more information.
Thanks, everyone. They can have that information to call a licensed clinical professional in the middle of